You're at the cutting edge of cardiovascular sciences. I'm John Cooke. I'm professor and chair of the Department of Cardiovascular Sciences here at Houston Methodist. And we have a very special guest today, Dr. Stefanie Dimmeler. And we're going to have an introduction by my colleague, Dr. Lai, who is also a faculty member in our Department of Cardiovascular Sciences. Dr. Lai, would you like to introduce Dr. Dimmeler?
Of course. Today, it's my privilege to introduce our special speaker, Dr. Stefanie Dimmeler, who is a renowned figure in the field of cardiovascular research. And Dr. Dimmeler got her PhD degree from the University of Konstanz in Germany, and then completed a fellowship in experimental surgery at the University of Cologne and in molecular cardiology at the University of Frankfurt. She is a professor of experimental medicine since 2001, and since 2008, she started to lead and become the director of the Institute of Cardiovascular Research Center for Molecular Medicine at the University of Frankfurt. Her research is focused on the pathophysiological role of vasculature with the aim to develop new cellular and pharmacological therapies to improve the cardiovascular disease treatment. Her pioneering work and exceptional contribution on stem cell biology, vascular biology, non-coding RNA, and all their role in cardiovascular regeneration have earned her a lot of Advanced Investigator Awards and numerous awards, including the recent Otto Warburg Medal in 2022, among others. She is also the spokesperson of the Cardiopulmonary Institute, which is funded by the Excellence Strategy Program of the German Research Foundation, and a spokesperson of the German Center for Cardiovascular Research. As a distinguished female scientist, Dr. Dimmeler's journey in science is always served as the inspiration for all the female scientists around the world, including me. So today, thank you so much, Dr. Dimmeler, for joining us. I'm looking forward to hearing about your insights and the visions of the new interface you recently discovered that can control cardiac aging. Thank you.
Dr. Dimmeler, Stefanie, so nice to see you again.
Thank you very much. It's very nice to see you as well, John, and also your colleague. May I share my screen?
Oh, in just a moment. Maybe we can talk for just a second about what's going on in your life. You are going to be talking about cardiac aging, and you managed to stay very youthful yourself. So tell us what your secret is. How are you maintaining your cardiovascular health? How are you maintaining your youthfulness? Do you have any tips for us? Anything that we should know?
I think exercise is certainly beneficial. So this is maybe no new news, but it's consistent over all studies. And I love exercise, but this is maybe also what keeps you young is to be active, I think, in general. Otherwise, I think, yeah, it's also a bit luck and genes, yeah.
You've always been an exercise fan. I've known that. Tell us what you're doing now for exercise.
Oh, I train for a triathlon, but only a small one because I'm no longer as active as I have been. So I do swimming, running, and biking.
Wow. Wow. How long was it?
As said, previously I did more. Currently I don't have so much time, but I still love it, yeah.
Yeah, wonderful. Well, it seems to be working. Do you have any questions for her before we start?
I would eager to hear what Dr. Dimmeler wanted to share with us.
Yeah, so why don't we, I know you're on a short time schedule here, Dr. Dimmeler, so why don't you go ahead and share your screen with us, and let's hear what you have to say about cardiac aging. It's something that's of great interest to all of us.
So I try now to share my screen, and maybe you can tell me if
we can see your screen
see
now. It's not in presentation mode, however.
Now better?
There we go. Much better.
So
that's perfect.
And so I'm ready to start, and would like to now. I hope everybody can see my screens. I would love to discuss with you now some aspects of cardiac aging, and of course, aging is a very important risk factor for cardiovascular disease. It, as you all know, it leads to atherosclerotic lesion formation. It's one of the risk factors together with the classical risk factors. And consequently, this of course leads to myocardial infarction, and this of course leads to heart failure with reduced ejection fraction, as we all know. But aging additionally also is affecting the heart directly without vascular, let's say large vessel diseases. And this is leading to a different type of heart failure, which is called heart failure with preserved ejection fraction. It's associated with diastolic dysfunction and fibrosis and microcirculatory dysfunction. And actually, the heart failure with preserved ejection fraction is increasing in incidence because we all get older, luckily, I must say. But this is, as you see here on the left panel, the heart failure with preserved ejection fraction is particularly driven by age, while heart failure with reduced ejection fraction still is increasing with age. But as you can see, particularly in females, there is a strong incline with aging. Heart failure with preserved ejection fraction also has many comorbidities. So aging is clearly one driver. As you can see here in the middle, it's driving all the different aspects and supports heart failure with preserved ejection fraction in conjunction with obesity, hypertension particularly. And on the lower panel, you can appreciate the mortality of heart failure with preserved ejection fraction. It's a bit less than heart failure with reduced ejection fraction, but still there is a strong mortality after 2 to 3 years after diagnosis. So together, age leads to different types of heart failure and can lead to a high morbidity and mortality in the Western world. What are the hallmarks of the aging heart leading to diastolic dysfunction? Is including, as I already mentioned, fibrosis, but also inflammation, mitochondrial dysfunction, and increases of cardiomyocyte cell death. There had been many molecular mechanisms associated with cardiac aging, which may together contribute to this aging phenotype, as listed here, for example, telomere shortening, acquired mutations, and also non-coding RNAs. We felt that it's particularly important to study aging in the concept of the different types of cells in the heart. Of course, in the past, there are several people working on cardiomyocytes, fibrosis, and endothelial cells, but we felt there is a need to put these different cells together because they together contribute to cardiac homeostasis and thereby are required to prevent cardiac aging if you want to treat it. So mesenchymal cells and endothelial cells together with immune cells have a strong impact on cardiac dysfunction. So we studied the change of cardiac aging on a cellular level by using, on a single cell level, by using the new technology. And this study has been spearheaded by Julian Wagner as a PhD student together with Guillermo Luxan. You see, they really like their studies. You see them in a costume for carnival. And we studied 18-month-old mice with comparison to young 12-week-old mice to the beginning. We used single-cell RNA sequencing, and for the heart, you have to adapt this method to nuclear sequencing because cardiomyocytes are too big. And basically, I think everybody now knows this technology, but for those of you who have not been exposed to it, it really allows you to study the transcriptome in each different cell. This leads to then the possibility to cluster cell types, and you can appreciate then individual cell signatures in like a type of fruit salad in comparison to a smoothie. Before you just took the whole bunch of tissue and then you get a mixture of gene expression. And with this increased resolution, we aim at understanding much better what is the effect of cardiac aging. As said, we compared young and old mice hearts at the beginning. And on the left-hand side, you see the single nuclear RNA sequencing clustering of cells, and you can appreciate the different cell types. And the old and the young hearts with N3 per group, really nicely the cells clustered to the different populations of cells. And it was at that time, it was quite a significant and high number of nuclei which we sequenced. And this data set is also published if you want to use it. We first of all addressed the question, what cells are, how are the cells regulated and what type of cells is mostly affected by aging. And therefore we assess the differentially expressed genes, and you see here the different clusters of cells, and in the outer ring you see here the upregulated genes, in the inner ring you see the downregulated genes, and you can appreciate that fibroblasts really have the most profound regulation of genes, followed by cardiomyocytes, but also endothelial cells are significantly affected. Second, we asked the questions whether aging may be inducing a transcriptional changes in all cells in the same way, meaning like typical senescence markers. But surprisingly, we found out that only 11 genes were regulated at all different cell types, and the majority was strongly cell type specific. So fibroblasts, immune cells, endothelial cells, and cardiomyocytes have much higher numbers of uniquely regulated genes compared to the common genes. This suggests that fibroblasts are mostly affected by aging. Maybe this is not a surprise, but also we found that genes are regulated in a cell type specific manner, which was, at least to us, quite surprising. With this, we now started further to dig into details and assess the different types of cellular responses during aging. And for the sake of today's talks, I will focus on the vasculature. So we specifically addressed what is the effect of aging on the microvasculature. Why this? So endothelial cells have important functions. They may not be seen as the major cell contributing to heart, but you see here in these immunostainings that certainly endothelial cells cover the entire heart, and you would not see the cardiomyocytes in between really, because the endothelial network is so dense here, as you can see here by this green staining. Endothelial cells have important function. They contribute oxygen and nutrient supply. They have a metabolic control function, but also, and this has not been studied so well, is that they export waste. They control barrier function, and this is meanwhile clear that the angiocrine factors produced by endothelial cells are essential for tissue homeostasis and also repair and regeneration in other organs. With this in mind, and looking into endothelial cell interactions, we know already from the literature that endothelial cells can regulate cells in other cells in the heart by providing paracrine factors as known as angiocrines, but also the other cells of the heart, cardiomyocytes, fibroblasts, and immune cells. There's a strong crosstalk together with endothelial cells, which of course maintains, as I said, tissue homeostasis and also repair and regeneration processes. To assess what is the impact of endothelial cells, we looked in the significantly regulated genes. And besides some genes which we were expecting, we were very surprised to find very strong Go terms associated with nerves. At the beginning, I thought that this is just an artifact because usually you would not think about nerve-related genes in endothelial cells. But seeing such a profound list of significantly associated pathways contributing to axon guidance, axon injury, neural cell death, and apoptosis suggests to us that there might be a crosstalk between endothelial cell and nerves. So our hypothesis was that maybe in the aging heart, endothelial cells may interfere with nerves, possibly by a paracrine crosstalk. Actually, if looking in the literature, it's very well known since centuries that nerves and vessels align. This has been initially described in 1546. You see here the original drawings, but also subsequently, if you now use more modern technologies to study nerves in the heart, you can appreciate this crosstalk. On the right-hand side, you see here 2G1 staining. This is a pan-neural marker, and you can appreciate the nerve bodies which are outside of the heart, and then these are just the axons invading into the heart. You see here the protrusions here into the left ventricle. There are several nerves invading the heart. You see here the parasympathetic, sympathetic, and the regulatory sensory nerves, and all of them together contribute to a dense network of nerves in the heart. Studying more deeply the interaction between nerves and vessels, you can appreciate here a double staining with smooth muscle actin in pink, and the red microcirculation, and in green again the nerves aligning with this vasculature, both with the larger arterioles but also with the microcirculation, suggesting there might be a neurovascular unit in the heart, and maybe there might be an effect of aging on the innervation. So to study this, we further looked in more detail, and this now shows you cross sections. You see on the left panel here the epicardial to endocardial staining of 2G1 again, And you can appreciate in the young heart that there is a staining from the epicardium towards the endocardium, while in the older hearts, you can see only remaining stainings in the epicardial, while the axon invasion into the old ventricle appears to be reduced. Interestingly, this was only seen in the left ventricle and not in the right ventricle, where axon density was similar in young versus old hearts. Second, we assessed when this decline in axon density occurs. And this was also surprising to see that the decline in axon density, as assessed again by TUCI1 positive area, it declines already with 16 months of age. This is relatively young. It would reflect the 50 to 60-year-old human, and it further declines to 22 months of age. We also found that this effect on age is affecting sympathetic, parasympathetic, and sensory nerves in the left ventricle, demonstrating that this is not a one specific type of nerve which is affected, but rather the entire nerve network in the left ventricle seems to be declined. In addition, we looked into HFpEF models. I initially mentioned that HFpEF is the typical diastolic dysfunction we see in older humans also, and this can be also induced not only by age, but also by L-name high-fat diets given for 2 months. This is this Calgattarella paper published in Nature some years ago, and you can appreciate that also under these conditions, there's a reduction in innervation, suggesting that HFpEF, as well as aging alone, has an effect on axon density in the left ventricle. So these data suggest that we have a reduction of axon density in the heart, particularly in the endocardium and the wall of the left ventricle. And of course, the key question now was, what is the mechanism? So how does aging affect the endothelial nerve crosstalk? To get some hints whether endothelial cells may be really a driver of the decline in axon density, we studied the gene expression, as said, in endothelial cells. And we found among the genes which are significantly regulated, strong regulators of repulsive signal. Repulsive signals are signals which can lead to a regression of axons. And this is including semaphorine 3A, NTN1, netrin1, but also SLIT3. All of them are increased in old endothelial cells, in old heart endothelial cells compared to young heart endothelial cells. At the same time, in aged hearts, neuroprotective signals such as VEGF-B were declined, as were others who also were shown previously to have a neuroprotective function. This data suggests that aging leads to a disbalance of neuroprotective versus repulsive signals. And to get some first hints about the specific and causal role in the process, we started to study semaphorine 3A because this was the highly regulated repulsive signal. And for this gene, it has been well studied that it has an effect on heart rhythm, patterning, sympathetic axon growth, and that it also attenuates electrical remodeling. And we thought to study this as a proof of concept that endothelial cell might have a crosstalk effect on axons in the aging heart. First of all, we looked into protein expression of semaphorine 3A and could confirm that indeed in old hearts there is an induction of semaphorine 3A protein expression compared to young hearts, as you can also see here in these immunostainings. Second, we studied whether semaphorine 3A indeed can lead to a decline in axon density. And for this, we used human iPS-derived cardiac organoids in collaboration with Jaya Krishnan's group. And indeed, we could find that recombinant semaphorine 3A leads to a decline in these nerves, which are also growing in these human iPS-derived cardiac organoids and are declined by addition of recombinant semaphorine 3A. Subsequently, we studied whether endothelial-specific overexpression of semaphorine 3A could indeed lead to a reduction of nerves in the heart. And for this, we teamed up with Oliver Müller and Christian Kuppert, who developed an interesting tool to induce a higher affinity for AAVs to endothelial cells. And in combination with endothelial-specific promoters, we found that we can use these AAVs to target cardiac endothelial cells. You see here the induction of semaphorine 3A in endothelial cells, while in non-endothelial cells, these vectors are not inducing semaphorin 3A. And by using this tool to induce endothelial cell semaphorin 3A expression, we could show that this leads to a decline into G1 positive areas, as shown here, suggesting that endothelial cell-specific overexpression of semaphorin 3A is sufficient to induce a reduction in axon density in the heart. So putting this together, we have shown that aging leads to a surprising change in repulsive signals and neuroprotective signals. This is in part mediated by semaphorin 3A. We also found an upstream regulator which controls semaphorin 3A in aging. This is a microRNA called microRNA 145, which is declined in the aging heart, leading to an unleashment of repression of semaphorin A and increase in this repulsive signal. Together, we suggest that denervation may be one of the things we should add to the hallmarks of aging in the heart, together with the already studied different types of effects we have observed before, we and others, of course. With this in mind, we questioned what could be a common upstream regulator which controls these processes in the heart. And of course, there are many hallmarks of aging, as summarized here, and cellular senescence certainly is one of them, which can be induced and is induced in the heart as well, and may be an upstream regulator. Senescence can have a double-edged role, so short-term senescence may be also a beneficial effect in repair, but a chronic induction of senescence leads to the secretion of so-called senescence-associated secretomes, SASPs, and they can contribute to aging and chronic heart dysfunction. Actually, we found that in endothelial cells, which are continuously passaged to induce senescence, semaphorin 3A can be found on gene expression level being induced, but also we found semaphorin 3A in the supernatants of these endothelial cells, suggesting that possibly semaphorin 3A may contribute to the senescence-associated secretome and may play thereby a role in reducing axon density. To study this hypothesis that maybe senescence contributes to this decline in axon density, we first of all looked in the time course when senescence occurs. And in the upper panel, you see here acidic beta-galactosidase staining. This is a measure of senescence. And you can again see at 16 months a first induction of senescence associated at the same time with this decline in axon density. So the time course would fit to the induction of axon density by the occurrence of senescence. Second, we questioned whether then the typical senescence model, like a TERT-deficient mice, may also show a decline in axon density. And indeed, TERT-deficient mice, which show an increase in senescence, show a reduction in G1 positive areas, as you can see in the quantification and in these images on the right-hand side. Of course, TERT knockout mice are globally senescence-inducing mouse models. And to study whether endothelial cell-specific induction of senescence may be sufficient to induce this decline in axon density, we were very happy to team up with Selma Osmanik-Myers, who developed an endothelial cell senescent model by overexpressing pogerin, which is an age-inducing, senescence-inducing protein in endothelial cells. And in these endothelial-specific induction of senescence models, we could also confirm a decline in axon density, demonstrating a direct causal role of endothelial senescence in inducing declines in axon density. To bring this one step further, we also looked into cellular models in vitro again. Here we cultured again endothelial cells for long-term passages, which induces senescence in these endothelial cells. Then we took the supernatants of these endothelial cells and treated primary mouse nerves. And you can see here that these senescence P15 supernatants induce a decline in nerve density and the axons. You can also see this in the quantification on the right-hand side. And interestingly, this was rescued, at least in part, by the addition of soluble NRP1, which is acting as a decoy for semaphorin 3A. So blocking semaphorin 3A activity in the supernatants prevented the induction of nerve decline in nerve density, in axon density in these cultured dishes. So in summary, these data suggest that denervation is associated with increased senescence. The induction of senescence reduces axon density in the heart, and this can be mirrored by supernatants of senescent endothelial cells in culture, which also reduce neural growth in vitro. Of course, the next question was whether we can interfere with the senescence and thereby rescue axon density. To do so, we used so-called senolytics. Senolytics are drugs which had been developed to favor apoptosis in senescent cells and kill senescent cells in tissues. There are different types of senolytics meanwhile studied. One has been entering clinical phase 1 trials also. This is the combination of dasatinib and quercetin, one of the first generation senolytics. And this has been published recently in Nature Medicine, if you want to look this up. So this could be potentially also clinically used. And we use this combination of dasatinib and quercetin in our mouse models to study whether the removal of senescent cells may restore axon density. The study design was that we treat we treat young and old mice with placebo, and then the old mice also with the senolytics. And you see here on the upper panel that indeed the senolytic cells were gone, or let's say reduced after senolytic treatments. This is the old mice with placebo. This is the old mice with senolytics. Again, this acidic beta-galactosidase staining, and you see here a reduction also in the quantification on the right-hand side. The removal of senescent cells by the senolytic treatment also restored axon density. You see here the 2G1 staining, which is almost back to the young controls and significantly augmented in comparison to the old placebo-treated mice. Also, this is shown here in the representative images. Of course, the question was whether these senolytic treatments really restores also the transcription. And to do so, we used single-cell sequencing in these mice. And again, we found that the regulated pathways in the senolytic treated mice really looked, this nerve system development GO term was significantly changed. And if you look in the detail in these regulated genes, we could find again an effect on semaphorin 3A. So senolytic treatments reduced semaphorin 3A expression in the endothelial cells, while also neuroprotective signals such as VEGF-B were significantly augmented, suggesting that the senolytic treatment really changes also the gene expression in these clusters of endothelial cells in the aged heart. But of course, the most important question now is, what are the functional consequences of the denervation rescue by senolytics, and what is the effect? We are still studying this. Innervation has many effects in the heart, so one of which is the effect on heart rate variability. It's known that elderlies have a reduced heart rate variability. This means they can no longer react to stressors in a way like young individuals do. In addition, a denervation can lead to silent ischemia and arrhythmias, as illustrated here. This is particularly shown for diabetic models and also humans. And then, of course, nerves have a very important role in regeneration. So if you reduce pharmacologically or surgically nerves, there is a lack of regeneration in postnatal mice models, suggesting that these nerves are really important and will provide growth factors involved in regeneration. And finally, innervation is controlling inflammation. So there are many studies, not in the heart, but in other tissues, that inflammation can be linked also to nerves and that they can control inflammation in different tissues. So what is the effect of our senolytic treatment in our mice hearts? So we studied all of these aspects which could be changed by the innervation. And first of all, we looked into the heart rate variability. And you can appreciate here that the senolytic treatment rescues the old heart reduction in heart rate variability. Interestingly also, and this was also surprising to us, in old mice, you see here a change in the day-to-night rhythm. So the circadian rhythm is disturbed. And this is also partially rescued, as you can see here, in the senolytic treatment. In addition, if you take out the hearts and pace them to study arrhythmias, there is also a decline in arrhythmias in the cellular treated mice hearts and compared to the placebo control. In addition, there was a mild but significant effect on inflammation. So CD68 positive monocytes, macrophages were declined with senolytic treatments. And finally, and most importantly, diastolic dysfunction, which is one of the hallmarks of aging functionally, which was induced by aging in the placebo controls, was declined again in the senolytic treated mice hearts. These data suggest together, and this is my summary slide here now, that senescence of vascular cells is sufficient to induce the reduction of nerve density. We have data suggesting that semaphorine 3A, but maybe also other pathways are disturbed and contribute to the reduction of nerve density. The treatment of mice with cellulytics, which remove senescent cells, was sufficient to restore nerve density. It leads to a normalization of heart rate mobility. It leads to a reduction of electrical instability and an improved cardiac diastolic dysfunction. So together there are more data in the publication, which you can find also more insights if you are interested in. The last two slides, I would like to bring this a bit also in the context. So our data would suggest that the vasculature plays a key role in aging. And indeed, there had been a study by Elliot Keshett's group already 2 years ago, and he showed that low dose, but it's important to keep low dose VEGF expression, that this is sufficient to expand the lifespan of female and male mice, as you can see here. And he looked into the aging phenotype of many different tissues, interestingly not the heart, but he showed, and this group showed, that VEGF and maintaining endothelial cells young also maintain organ healthy and organ young. Second, also innovation seems to play an important role more and more, not only as we have now shown in the aging heart where denervation occurs, but also there is a neuroimmune control of atherosclerosis. There are more pathways controlling brain-spleen communication and cholinergic sympathetic pathways in immunity. And also there has been very interesting studies recently by Stefan Engelhardt's group, which you would like to look into. So there appears to be a very important crosstalk between nerves and the heart and the vasculature, which is worth to further study. With this, I would like to thank the people who did the work, particularly Julian Wagner, as I mentioned before. He spearheaded all of these data and this project together with our team and collaborators. Particularly, I've mentioned already some of them in the slides, but also more, particularly with the help of electrophysiological measurements and our entire team, which is shown here, which without them, we wouldn't have been able to perform this extensive study. Now I would like to thank you for your listening, and I'm happy now to discuss with you any open questions.
Professor Dimmeler, once again, you're leading the way. Just a spectacular work. You briefly alluded to the hallmarks of aging, which were recently updated at the Copenhagen meeting. I think they're going to need to be updated again to add denervation as a hallmark of aging. It's just spectacular work. I had a couple of questions for you, but before we go to my questions and those of my colleague here, I want to let people at home know that they can call in. They can text 37607, text DZHK to 37607, and then you can put in your message. Or you can go online to pollev.com, that's POLLEV.com, and enter DZHK, and then you can ask us your question. To start, you mentioned at the very top of the program that women are more likely to have a heart failure with preserved ejection fraction. Tell us what you think is going on there. What's the mechanism of that gender difference?
So it's a very interesting question, but also an unsolved question. I think this is worth more efforts because it's interesting. We have a higher incidence, but at the same time, then the lethality and the mortality is still reduced in females. So it's a very complex, a higher incidence, but at the same time a less severe phenotype. What is the case? What is the role? It's so far not fully understood. There may be, of course, hormonal issues, but these are postmenopausal women, and so therefore maybe this is less important. There may be relevant signatures also on the X chromosome. We have a study now looking into the loss of the Y chromosome and diastolic dysfunction. So maybe males and females, of course, differ with respect to the Y chromosome. There are many things we could cause these differences in females and male, but at least to best of my knowledge, this is not yet solved.
So let's stick on heart failure for a moment. You mentioned that with aging, there's a denervation of the heart, evidence for that, reduced innervation, sympathetic and parasympathetic innervation. And furthermore, you showed that endothelial cell production of neurorepulsive factors like semaphorin might be playing a role. If you biologically manipulate the heart so that the endothelial cells are producing more semaphorin or more progerin to accelerate aging, presumably you see more denervation, and I guess you did show us that, but do you see more heart failure in those animals? Did you see any evidence for reduced cardiac function?
I haven't shown you all of this. We did some additional studies, not for all models, but for some of these models we found also let's say an increase in diastolic dysfunction and also fibrosis. So suggesting that it's not only the innervation which is changed, but also pathophysiological consequences are induced by these models. Of course, the prokaryotic mice model is not only affecting innervation, but also the endothelial cells are senescent and there's a lot of inflammation going on. So our data would not necessarily be sufficient to really pinpoint this specific effect. But it's rather that the whole phenotype is induced, which can have multiple consequences together leading to the phenotype. We have some maybe this. Yeah.
No, go ahead, Stefanie, please.
The point is, of course, what you would like to point out is what is the sole impact of the innervation. So to what extent the reduction of innervation is causing this alone. And this is something which we have not yet fully studied. So we just pharmacologically blocked innervation, and this leads also to some fibrosis. But of course, it's also quite toxic. So we would need now to do more studies to better manipulate the individual different nerves and then look what's happening in the heart.
You know, just
in the context of aging.
Before I turn to my colleague here, I have one more question along those lines, and that is, there is a situation clinically where the heart becomes denervated, and those patients do have a microvascular problem. I'm talking about the transplant patients, and when we do a heart transplant, that heart that we put into the chest of the patient is now denervated. And as you know, we do see over time this allograft vasculopathy, which is a narrowing of the lumen of the coronary tree all the way from the epicardial arteries to the coronary microvasculature. That's been presumed to be entirely due to an immune, chronic immune response. But is it possible that the denervation itself is playing a role?
Certainly it could be. So particularly sensory nerves, of course, play a very important role also in the vasculature, in the vascular control. It's worth study, but also has to say that in transplanted hearts, in some patients, the nerves also can regrow. So it would be really interesting to look into more details, whether there's an association with nerve regrowth and vasculopathies and maybe heart rate variability in vasculopathies. So I couldn't find these details, and if you have collaborators having a heart transplantation program, I would be very keen on looking into this. It would be interesting to find out whether there is an association.
Let's have an offline conversation about that, because we have a very busy heart transplant program here, so that would be fun to look into. Dr. Lai.
Yes. My first question is more general. So regarding the senolytic drug, what's your suggestion? So do you recommend that I can suggest my friend, elderly friend, to take this drug? Or also, do you see the effect is age dependent? So let's say if I take the drug, what's the difference? Can I get any beneficial effect from this drug?
So I say quercetin you can buy off the shelf, but you have to take quite a high concentration, and the combination is more efficient, and this includes dasatinib. This is, of course, a drug, tyrosine kinase inhibitor, which also has side effects. So I would not recommend taking this before we have the phase 3 clinical trial. But there are other senolytics like fisetin and we are also looking into more specific signatures of endothelial cells. Maybe you can target this more effectively in the future. So I think not yet ready that you should take this combination of drugs. Quercetin certainly, I don't think that it harms, but it's of course also an antioxidant. But as said, the concentration is quite high. And one has also to say that I'm a bit, let's say, not worried, but if you have a lot of senescent cells, so maybe it's better to take these drugs early on, where you have a small amount of senescent cells. If it's too many senescent cells in the tissue, of course, the killing of these senescent cells can also cause harm. So I think it would be interesting to study when is the best time to take senolytics and induce senescent cell death, because it must be early on, too late maybe inducing even harm. So we need good biomarkers. So that the answer to your question, maybe you shouldn't wait too long to take senolytics if they are available, but rather try to clean the senescent cells over the time, yeah.
Or maybe exercise early.
Yeah.
Right?
exercise early. This also prevents senescence, yes.
Yes.
You know, I do know colleagues that are taking senolytic agents like fisetin or quercetin, yeah. I'm not, and you know, I do wonder about the potential adverse effects of senolytic therapies. You know, there are utility for senescent cells. I mean, senescence is thought to be play a role in preventing cancer. Senescent cells also seem to be involved in healing. Tell us a little bit about that. What's the role of physiological roles of senescent cells?
So this is a super interesting question, because there are published data but also unpublished studies by investigators that senescent cells are also important for wound healing. And you can, of course, also, for example, if you have fibroblasts becoming senescent, maybe this also prevents fibroblast proliferation, and is maybe a way to stop also fibrosis even. On the other hand, of course, if you don't look this in an acute situation, but rather chronically, maybe it's really good to remove the senescent cells, because at that time, if you remove the senescent fibroblasts, maybe it's also not proliferating anymore because it's removed. So, but it's a clear evidence that in acute situations, you need repair processes are involving senescence. And I also think we need, senescence is not senescence. I think it's a term which is used, of course, I also use it, but the measures of senescence is difficult. We have different senescent marker genes in different cells. We don't even know how senescence is maybe not the same in all different cell types. So I think it's more complex than just to say senescence is good or bad. It certainly has a double-edged role, and also maybe specifically having different signatures also in different cell types in different organs.
So, because you mentioned denervation and senescence at the same time, I don't think they are the same thing, right? One is reduced nerve density. One is a quality, kind of a quality difference. So, so do we need to target denervation or senescence? My essential question is.
actually, we don't, honestly, we don't know yet whether you would like to target axon growth, yeah. Because of course an excessive axon growth is certainly not good. And I think targeting senescence is maybe at the time being, even with all the caveats we have just discussed, also with John saying that senescence may have an anti-cancer role also, targeting senescence would certainly also reduce inflammation and maybe maintain organ function by removing the senescence-associated secretome. So I think it's more likely that this has a broader impact. Innervation, and this is just also a take-home I would like to add, it's not that we have this denervation in all organs. We have it in the left ventricle, interestingly, not in the right ventricle. And also in different organs, this nerve-vascular interface is a bit different. So for example, in the lung, we see an increase in innervation, and there the nerves align not so much to the vessels, but rather to the bronchi. So the different organs have different innervation patterns also. It's maybe in the heart different than in other organs as well.
Yeah, just to follow on from there, Stefanie, you've done a tremendous amount of work in vascular biology. We were talking about the heart today, but tell us a little bit about the role of senescence in the vasculature, in the peripheral vasculature, and the role of denervation.
With respect to senescence, there are also studies showing that senescence is reducing senescence. Like, for example, blocking NF-kappa B can reduce senescence, and that this leads also to an improvement, or let's say reduction in atherosclerosis and vascular inflammation. With respect to the innervation, it's interesting. So the study from Christian Weber has shown actually that innervation is in this a reduction in innervation in the vasculature may be inducing, maybe reducing inflammation. So there is a strong connection with tertiary lymphatic organs in the vasculature. So we are still looking into what's happening in the heart, because they looked in our aortas, and to get some more insights in which vascular bed the innervation plays what type of role. So I think there is worth more studies and looking in different vascular beds and look what nerves do. It's maybe also not this, of course nerves have different functions. As said, there's sympathetic nerves, there are sensory nerves, and so there are different effects also of different nerves possibly. So I can't give you now a very brief insight. I can just say that there is really a need to better understand how nerves control the vasculature and better understand the interaction between them.
I think there's some evidence, and I can't pull up a reference offhand, but I think there's some evidence that in paralyzed limbs, denervated limbs, there is an impairment in the microvasculature, a loss of the microvasculature, or a reduction of the microvasculature. And I guess the thought has been that that's because of a disuse syndrome, but maybe it's a much more active process, such as what you've described today. The denervation may be because you're losing that vasculotrophic effect of the nerves. Perhaps that's contributing to the loss of the microvasculature. Do you have any thoughts about that?
So we have some preliminary studies suggesting that in neuropathies also there is a reduction in nerves, which are also aligning with vessels in the limbs. So I think it's your idea that this could be a consequence of microcircular dysfunction, that the nerves decline, the axon density in the nerves decline in this tissue as well. This could be likely, although we did not yet have causal studies, just associations.
And there are also in diabetics, there's this phenomenon of neurotrophic ulcers, right? I mean, an area that is where there's denervation due to the metabolic abnormality, you're much more likely to get an ulceration.
Yes.
So again, that could be due to an impairment of that vascular neurotrophic influence of the nerves on the vasculature.
Yes.
Yeah. You know, we did some work, it was quite a few years ago, when we were looking at angioplasty and looking at the effects on the sympathetic nervous system of the vasculature of angioplasty. And we were surprised to find that after an angioplasty, the myointimal hyperplasia that occurred was associated with an increase in catecholamine content in the vessel wall. And this was weeks after the injury, and we were able to show that we could inhibit the myointimal hyperplasia to a certain extent by anti-adrenergic agents. And we never followed up on that, but I've always wondered what the role is of innervation in abnormal vascular growth, and in this case, myointimal hyperplasia. On the flip side of what you've been talking about today, what is the role of innervation in the response to injury, in regeneration, or in an excessive proliferative response to an injury, as you see in myointimal hyperplasia? Any thoughts about that?
So I can just refer to our study where we looked in the time course after acute myocardial infarction. And it's very interesting. So first of all, we see an increase in innervation, which is maybe also consistent with an electrical instability, because hyperinnervation is as bad as hypoinnervation, maybe even worse. And then, interestingly, if you look after 4 weeks to 8 weeks, when you have the remodeling of the myocardium ongoing, then the nerve density declines to below baseline levels. So there is really a time course after acute myocardial infarction associated with a long-term impact. What this functional role is, we have to understand. We also don't know what type of neurotrophic factors. I think, of course, brain-derived neurotrophic factors is known to be important in regeneration. From Rich Lee's data, we know this. But what really the nerves secrete, maybe also others than protein, we don't know yet. So we try now to find out the secretome of the nerves also in the heart to find out what they release. Maybe this helps us to get some more hints than what could be the function in repair and regeneration.
Interesting. Dr. Lai, any other questions? Well, I think, Stefanie, this has been wonderful. We've learned a lot from you today. You continue to do spectacular work, really cutting edge, leading the field as usual. And it was such a pleasure to have you on the show today.
Thank you very much. It was my pleasure.
That was Professor Stefanie Dimmeler talking about her recent work on denervation and the aging heart. A wonderful talk. Thanks again, Professor Dimmeler. You've joined us today at the cutting edge of cardiovascular sciences. Thank you for attending.
Thank you very much.